So good evening, everyone. My name is Alfonso Aguaron, and I'll be moderating today's webinar. I would like to welcome you all to this online session on smoldering myeloma. So, as part of the Myeloma Patients Europe educational programs, this session has the aim on informing patients, relatives, and advocates about this particular form of the disease and the new insights in its treatment. So, the talk will be given by Dr. Maria Victoria Mateos from the Haematology Department at the University Hospital of Salamanca in Spain, and Dr. Jens Hillengaß from the Haematology and Oncology Department at the University of Heidelberg in Germany. So, on behalf of Myeloma Patients Europe, Dr. Mateos and Dr. Hillengaß, I would like to thank you for your collaboration and for providing all of us with the latest information on this topic. So, for your information, this webinar will be fully recorded and uploaded on the Myeloma Patients Europe website, which is www.mpeurope.org. So, before we get started, I'd like to make a small summary on the webinar dynamics. As you know, the webinar is scheduled from 5:30 to 7 Central European Time, so the presentation will last about from 45 to 50 minutes, and then after the presentation I'll open a session for you to ask any question that you might have. We have already received some questions by email and we'll read them all, but you can also make yours live. So, you have the possibility to make your questions in two different manners. First of all, if you have a microphone, which is something that I strongly recommend you can press the raise hand button in your screen and I'll unmute you so you can make your question when it's your turn. Then the other possibility is to do that in writing through the questions and answers chat window. I'll get those questions and I'll read them to Dr. Mateos and Dr. Hillengaß. But I would really like you, in case you have the headset, you can make your questions live, so there's no problem. So without further ado, I wish you all a very interesting webinar, and I give you the floor, Dr. Hillengaß.
Yeah, good evening, ladies and gentlemen. First of all, I would like to thank the organizers, especially Alfonso, for this great opportunity to talk about this very interesting topic. I just came out of my patient visits, and I think it's really important, especially for patients in this setting of smoldering myeloma, because there are a lot of questions patients have, because for a long time we didn't treat those patients. We just said, you have smoldering myeloma, whatever that means, and then there was, we just waited and saw what happened. And this was for patients, I think, very demanding to cope with this situation. So I think we have a great opportunity tonight to show you the most recent developments in smoldering myeloma, especially in this stage of the disease. I will start with the diagnostics, what to do with a patient coming to our clinics or to private practice. We have a recommendation from the International Myeloma Working Group to do minimal diagnostic requirement or minimal diagnostics in patients. If your doctor does anything else, it might also be correct, but this is what is recommended to do in every patient. First of all, we of course ask our patient what was the reason why you're coming to your doctor. What is your medical history? We will ask what other diseases are present, what you know about your medical history, and we will ask about family history. Because it could be interesting to see if there are a lot of hemato-oncological diseases like cancers in relatives, especially in relatives of first degree, meaning siblings and parents. We will do a physical examination, and at least I, in my practice, mainly focus on myeloma symptoms like, of course, back pain, like edema caused by renal impairment, looking for skin and mucosa, if there's pale skin or a sign of an anemia, signs of any infections, and so on. So there's this kind of specialized physical examination and medical history. When we go for blood examinations, our laboratory examinations will be a differential blood count, not only hemoglobin, leukocytes and thrombocytes, but also a differentiation of the white blood cells, leukocytes. We'll do biochemistry, we'll look for liver function, renal function, especially renal function because it could be influenced by multiple myeloma. We look for electrolytes like potassium and calcium, especially albumin and beta-2 microglobulin are more interesting in the symptomatic disease, but at least in our clinic and also in the recommendations, we do it also in patients with smoldering myeloma, and LDH as a marker of cell turnover and CRP as marker of inflammation in the body are also in the lab results. What is very interesting, of course, is the monoclonal protein. First question, is it there? Is it really detectable? And second question, how high is the level? And we'll look into serum and urine, and the technique you use is so-called GL electrophoresis, and to differentiate the monoclonal protein like IgG, IgA, what you might have heard, the technique is immunofixation. We also count the immunoglobulins because it's interesting how the immunoglobulins are elevated. If you have, for example, IgG myeloma, IgG could be elevated. And on the other hand, it's also interesting to see if IgA and IgM, the other main immunoglobulins, are lower than the normal range. So we get an information on if there's another influence on the immune system in our patients. We also collect 24-hour urines. I know that at least in Germany some doctors don't do it because it's not very comfortable, especially for the patient, but the recommendations say that it's good, and we also do it in our clinic because we get some information we don't get out of other clinical or laboratory examinations. So we will still recommend a collection of a 24-hour urine to measure especially measure the light chain concentration of kappa and lambda. We also do a measurement of those light chains in the serum. This is a little bit a newer test, and it also gives interesting information, and we'll come to that during the session going on. It's a so-called serum-free light chain assay. So I talked about light chains. Maybe you don't really know what light chains are. There's an image on the screen now. The immunoglobulins that are produced by the multiple myeloma cells can be divided, or it's an image of them being divided into heavy chains and light chains. Those heavy chains are called IgG, IgA, IgM, IgD, and IgE, but the later two are not very common. So mainly it's IgA, IgG, and IgM, and IgM is again a little bit special because it mainly leads to another kind of disease called Waldenstrom's disease, which is rather a lymphoma than really a myeloma, but there are also patients, very few patients with an IgM myeloma. So those are the heavy chains, but we can also measure those light chains, as you can see, and they are called kappa or lambda, and they will come back to that in a few minutes. We still have to look into the bone marrow. I know that it might be painful. I hope it's not too bad. But we'll do a biopsy at first diagnosis, and we'll do an aspiration, meaning biopsy is a small part of bone we take out of the bone marrow, and the aspiration is getting some blood out of the bone marrow, mainly the pelvis, pelvic bone, and sometimes in the sternum, because if there's no possibility to get this aspiration from the pelvic bone. And we'll have to look if there is a clonality, meaning that there are cells coming in theory from one cell, and they are typical for monoclonal mono, meaning one, clonal plasma cell disorders. So we'll have to look into this clonality, if it's kappa or lambda, if it's IgG, IgA, and we'll see that on the cells and can differentiate between so-called polyclonal cells, which are usually there because you need them for immune processes. But if they are clonal or monoclonal, they have this potential of malignancy, and so we have to look into that. We also look into the genetics of those cells. It's becoming more and more important in cancer treatment and cancer diagnostics to see if they if the cells have changes in their genetic information, and there are three most important changes, or also mainly in symptomatic patients, but they are also interesting for smoldering patients, and they are so-called the deletion 17p, translocation 414, translocation 1416, meaning that in deletion 17p means that there's a small part of the chromosome 17 that is missing, and the translocation meaning that one part of a chromosome is put over to another chromosome. And we know that there are prognostic information coming out of those information. So here you can see images of on the left side of a smear. So we do an aspiration, we do a smear on a slide, and then we look into the microscope, and you can see those cells are plasma cells. As you can see here, they have this round cores and look a little bit like an egg in the pen. So on the right side you can see a histological slide of myeloma with those fat cells with those white spots. In the upper right corner there is a little part of a bone, and you can see those cells in between. And this is what we see in the microscope if we do this bone marrow biopsy and bone marrow smear. So, sorry, go further. We also have to look into the bone stability, because, as you might know, myeloma can impair the bone stability, can increase the activity of cells in the bone that are usually there to transform the bone. Like there are so-called osteoblasts building bone and osteoclasts destroying bone, but it's usually there that there's a turnover in bone. And in myeloma, those osteoclasts, those destroying cells, which are not ill, but are there, and they might be overstimulated by the myeloma cells, and so we have to look if there's any visible destruction of bone mass. And as you see, the skeletal survey is in brackets, meaning that we still have this as a standard, but we are working within the myeloma working group to change that to a so-called whole body low dose CT, because the CT has a higher sensitivity and specificity to differentiate those changes in bone, especially if they're very small, as it can be in early stages of disease. What we also can do now, according to the recommendation, is to do a so-called PET-CT, PET meaning positron emission tomography. And this combined with this computed tomography shows the turnover of cells, the cell metabolism in the bone marrow, combined with the mineralized, so-called mineralized bone, like the skeletal bone in this technique. So this is a combination technique, very interesting, but it's not available in every region. Even in Germany, we don't have access for every patient to this. This is very new, and we'll see if the future might bring this technique as a new standard. What is also recommended is a so-called magnetic resonance imaging, MRI, which is a not radiation-based technique. It's only based on magnetic fields, and you can see very good the soft tissue and the bone marrow in this technique. And of course, you only can have this if it's available in the clinic you're treated and you're diagnosed. Here are several images of those what is possible. On the left side, it's a so-called skeletal survey. I have just put those images you get out of the skeletal survey on one patient. The next slide is a CT, computed tomography. Then it's a so-called functional magnetic resonance imaging, showing black spots where myeloma cells are expected. Then there is a PET-CT. It could be at different colors, but as you can see here, there are small spots. Only one spot actually. I should have used one with more spots to see it better. But this is a low tumor mass, and there might be one spot. But it's difficult sometimes to differentiate between just an inflammation, like it could be on a joint when you have too many pressure on the joint, and the next, but it could also be malignant cells. And the next is a so-called whole body magnetic resonance imaging, where you can see the bone marrow, especially in the spine and in the pelvis. So this is imaging. If a patient is treated, just in short, if there is a treatment in case of smoldering myeloma, or we do, even if there's no treatment, if we decide that there's no treatment needed, we do again a repetition of those examinations after 3 months. We again do the medical history, physical examination. We investigate the serum and urine and some of the blood counts and the lab results I just presented. And we do imaging only if there is a clinical indication, meaning that you have new pain, or if there is neurological changes, you can again perform an imaging. If not, it's not always necessary to do follow-ups of the imaging. So this would be the first part of my talk, and I think I'll hand over to Professor Maria Mateos for the next part.
Okay.
Okay, so I'm going to switch. Yeah, I'm going to switch to the screen. So Dr. Mateos, you can see a button now on your screen. If you can press it, and you can start with your presentation. Yeah, that's it. We can see your screen right now. Perfect.
Okay. Good afternoon, everybody, and first thank you for the invitation to participate in this webinar seminar organized by Alfonso Aguaron, and also it's a pleasure for me to share this meeting with Jens Hillengaß from Germany. So after the definition previously described by Jens Hillengaß about smoldering multiple myeloma, when we have a new patient in our clinic with the diagnosis of smoldering myeloma, you probably know that the most relevant question is smoldering myeloma an important disease? Is it a malignant disease? What is the risk of progression to symptomatic multiple myeloma? And so this is what I am going to try to present to you during the next minutes. In this slide, you can see here, so I don't know, let me, yeah. In this slide, you can see here the risk of progression to symptomatic disease. And you can see first the outcome of patients diagnosed of monoclonal gammopathy, another plasma cell disorder in which the monoclonal component and the plasma cell bone marrow infiltration is usually very low, and the risk of progression to symptomatic disease is uniform and very low during the disease, 1% per year. By contrast, you can see here the risk of progression to symptomatic disease for patients with smoldering myeloma. And you can see as the risk is not uniform, and in fact we can distinguish between 3 different risk subgroups of patients. In green, you can see here this group of patients in which the risk of progression is really very low, 1% per year, identical to MGUS. You can see here in pink another second group in which the risk of progression to symptomatic disease is of approximately 3% per year. So the risk is intermediate. And finally, you can see here this group of patients in blue in which the risk of progression to symptomatic disease is much more higher, 10% per year. So what is important for the physician treating patients with smoldering myeloma, and especially for the patients? what a patient newly diagnosed of smoldering myeloma want to know if the patient is in this group at a high risk of progression to symptomatic disease, in this group at intermediate risk of progression, or a very low risk of progression to symptomatic disease. And this is what the hematologists have to do, because fortunately we know that there are some risk factors predicting progression to symptomatic disease. And here you can see a list of different prognostic factors predicting progression to symptomatic disease. And let me show you some of them because they are easy to understand for you patients and relatives. Dr. Hillengaß said that smoldering myeloma is defined by the presence of monoclonal component higher than 3 grams per deciliter and or plasma cell bone marrow infiltration higher than 10%, between 10 and 60%. So you can see here, if we consider these diagnostic criteria, we are able to distinguish 3 different subgroups of patients. You can see one group of patients in which you can see the median time to progression to symptomatic disease is almost 20 years, indicating that this group of patients are really at a very low risk of progression to symptomatic disease. What are the characteristics of this group of patients, of this third group of patients? Patients with plasma cell bone marrow infiltration inferior to 10%, and patients with the monoclonal component higher than 3 grams per deciliter. In the middle, you can see a second group of patients in which the median time to progression is approximately 8 years, so intermediate risk of progression to symptomatic disease. This second group of patients are characterized by the presence of more than 10% of plasma cell bone marrow infiltration, but the monoclonal component is inferior to 3 grams. Lastly, you can see this third group of patients in which the median time to progression to symptomatic disease is 2 years. So the risk of progression to symptomatic disease for this group of patients is high, 50% at 2 years. What are the characteristics of this first group of patients at high risk of progression to symptomatic disease? Those patients meet both criteria defining smoldering myeloma: more than 10% of plasma cell bone marrow infiltration and more than 3 grams per deciliter of monoclonal component. So you can see as the physician can identify the risk of progression to symptomatic disease. But in addition, we can use other risk factors such as abnormal serum-free light chain ratio. Serum-free light chain have been previously defined by Jens Hillengaß, and when a patient has an abnormal serum-free light chain ratio, you can see here as again the risk of progression to symptomatic disease is higher as compared with those patients in which the serum-free light chain is normal. Also, we can evaluate the risk of progression to symptomatic disease if we evaluate the plasma cells within the bone marrow. Here in this slide you can see in the left part, as we see usually the bone marrow compartment in a patient with multiple myeloma. Most of the plasma cells are clonal in orange, indicating that most of the plasma cells are malignant plasma cells. By contrast, in the right side you can see what we see when we evaluate the bone marrow of a patient with smoldering myeloma. Some malignant plasma cells, but also normal plasma cells. The group of Salamanca and also the Spanish myeloma group evaluated this proportion, the proportion of clonal of malignant plasma cells within the bone marrow compartment in patients with smoldering myeloma. And you can see here as also we were able to distinguish between 3 different subgroups of patients. A group of patients at very low risk of progression to symptomatic disease when most of the plasma cells in the bone marrow were normal, an intermediate group when some plasma cells were normal, some plasma cells were abnormal, and a third group at high risk of progression to symptomatic disease. Again, you can see here median time to progression of approximately 2 years when most of the plasma cells, more than 95%, are aberrant, so are malignant plasma cells. And this is what we usually do in the clinic for the evaluation of the risk of progression to symptomatic disease. We can also use the evolution of the monoclonal component. So when we see one patient in which the M component is stable during the period of time in which the patient is observed, you can see as the median time to progression to symptomatic disease is significantly longer as compared with those patients in which the M component is increasing, especially within the first 6 months. And this is another criteria that we usually use to stratify and to define the risk of progression to symptomatic disease. We can also consider the presence of cytogenetic abnormalities, and previously Dr. Hillengaß commented about the bone marrow and the cytogenetic profile done in the plasma cells within the bone marrow. When your plasma cells had cytogenetic abnormalities such as 414 translocation or deletion of 17p, we know that the median time to progression to symptomatic disease is a gain of approximately 2 years. By contrast, with no abnormalities are present or 1114 translocation is present, the risk of progression to symptomatic disease is really very low. Finally, Dr. Hillengaß also evaluated the role of imaging assessment, and just to say that PET-CT has been recently incorporated to our imaging tools to evaluate the bone disease, and also in smoldering myeloma, PET-CT has a role because when patients had a PET positive, again the risk of progression to symptomatic disease is significantly higher as compared with those patients in which the PET-CT is negative. But I would like to note that just positive, the PET, without any osteolytic lesion in the CT part. Why? Because Dr. Hillengaß previously mentioned that when a lytic lesion is present, the diagnosis is not a smoldering but myeloma. So just a positive uptake in the PET-CT. So this is the last slide of my first part of the presentation. This is what we usually do in our clinic to stratify the patients according to the risk of progression to symptomatic disease. And if the patient is at a low risk of progression to symptomatic disease, the patient can be probably called monoclonal gammopathy patient, and as Jens Hillengaß previously said, probably these patients have to be followed every year because the risk is really very low. When the patient is at intermediate risk and the median time to progression to symptomatic disease is superior to 6 or 7 years, these patients can be probably followed 2 times per year. But when we evaluate the risk of progression and the patient is at a high risk of progression to symptomatic disease, and this means that the risk of progression is approximately 50% at 2 years, we will discuss later about the management of these patients, but of course they need closer follow-up. And finally, within this high-risk group of patients, we can identify ultra-high-risk smoldering myeloma patients in which the risk is not 50% at 2 years, but 70, 80, or even 90% within the first 2 years of diagnosis. I am not going to speak about these ultra-high-risk smoldering myeloma patients, and now I would like to turn again to Dr. Hillengaß because he will explain the new definition of myeloma in which these ultra-high-risk smoldering myeloma patients are going to be included.
Okay, so Dr. Hillengaß, I'm going to share your screen now, so you can go ahead.
Okay. Thank you, Dr. Mateos. Very nice introduction to my next talk. As you said, and as you listeners heard, there's a new definition for multiple myeloma. This is the definition as it was for several years. It was presented in 2003, and there was a definition of so-called monoclonal gammopathy of undetermined significance, already mentioned several times, which with very low plasma cell infiltration in the bone marrow, with low monoclonal protein, and no so-called CREB criteria. And I'll tell you in just a few seconds what CREB criteria are. There is another part, and we are talking about smoldering myeloma with a higher plasma cell infiltration in the bone marrow, a higher monoclonal protein, but still no so-called CREB criteria. And of course there is symptomatic multiple myeloma with high infiltration of bone marrow, high monoclonal protein, and so-called CREB criteria. When you look into the evolution, so-called, of the disease of a patient, it can be in the monoclonal gammopathy stage for several years. This is just an example. And then the tumor mass, kind of this measured by the monoclonal protein, the secretory activity of those cells, can go up over, let's say, some years, or also in months or weeks. And then there's this so-called progression into symptomatic multiple myeloma. So there seems to be an increase in the dynamics of the disease. And you don't have to really read this slide, but it says that there are several changes in the cells themselves, changing them from this rather benign monoclonal gammopathy to this malignant disease called multiple myeloma, and in some patients even a so-called extramedullary multiple myeloma. And there is very nice work from the Spanish group about this, which is a more advanced stage of the disease. You have seen this curve already, and as Dr. Mateos mentioned, there are some patients with smoldering multiple myeloma with a very low risk of progression into symptomatic disease. And if you compare it to the MGUS patients, on the upper level there is the smoldering patients, and the lower level there are those MGUS patients, and it looks nearly the same. There's a very low rate of progression into symptomatic disease over time. But you have already seen, presented by Dr. Mateos, that there are other patients with, by definition, smoldering myeloma, or by the former definition, as I have shown you, they have a smoldering myeloma, no symptoms of the disease, but they have a high risk of progression into symptomatic disease. And it's very important to differentiate those patients, those with a slow risk compared to this high risk. And you have already learned that there are several parameters showing which group of patient you are in if you have a smoldering myeloma and have a specific constellation of parameters. So we really wanted to know if those patients have low risk and maybe don't need treatment for a long period of time, sometimes 10 years or more, and if we can define patients with a high risk of progression and look if they have a benefit if we treat them earlier, because if you treat a patient there will always or nearly always be side effects, and so we have to differentiate if a patient really has benefit from early treatment or not, and we think that those patients have a benefit from early treatment while those patients maybe don't have this benefit. So if you look into high-risk smoldering myeloma, as Dr. Mateos mentioned, there are several staging systems or risk stratification systems, one presented by the Mayo Clinic from the US with saying that if a patient has 10% or more plasma cells, monoclonal plasma cells in bone marrow, it is a risk factor, as well as a monoclonal protein of more than 30 grams per liter, and so-called free light chain ratio, as we mentioned, below or above a certain level. So this would be between this. There's the normal range of free light chains in the blood, but if you have a light chain ratio below or higher, it could be a risk factor for progression into symptomatic disease. As already mentioned by Dr. Mateos, there's also a definition by the Spanish myeloma group defining that if you have those atypical plasma cells, you might remember the slide from Dr. Mateos with those blue and red cells, if you have a high percentage of those atypical or maybe malignant plasma cells in the bone marrow, in this special technique called flow cytometry, it is a risk parameter, and also a so-called immunoparesis, meaning that those mentioned immunoglobulins that are not the monoclonal protein, like let's say if you have an IgG myeloma, and the IgA and IgM are below the normal range, it is a so-called immunoparesis, or if you have IgA, the IgG and IgM could be decreased. So this is a so-called immunoparesis, showing that there's already something going on in the bone marrow and that there are plasma cells pushing away the normal plasma cells. So as Dr. Mateos already mentioned, there's an ultra-high-risk smoldering myeloma, and the working group said we want to define ultra-high-risk smoldering myeloma that there is approximately a progression of about 80% within 2 years. This was a definition mentioned in a working group meeting in 2011, and they said, okay, we have to find those patients because they might have a benefit by treating them. So you could calculate that there is about approximately a progression of 40% per year. And then the working group looked into the literature and found several factors, as Dr. Mateos already mentioned, with this potential to define those patients. And the first thing that was found is a bone marrow plasma cell percentage, as we have mentioned already several times, bone marrow plasma cell percentage of 60% or higher. And the definition said that we need two groups, two scientist groups, defining those parameters as really significant prognostic parameters. And there is one group showing this here, Dr. Rajkumar and Dr. Wexman is another group. I'm sorry for the quality of the slide. I haven't found a better one, but you can see again there is a high risk and a low risk, and this high risk is with a steep increase, and this is just vice versa. There's a very steep decrease of this curve, showing that the patients are going on to symptomatic disease very early in this group and in this group, and both groups are this 60% or above. The same is here with the free light chain ratio. There is found that the cut point, let's say, of more than 100 ratio, meaning kappa divided by lambda or vice versa, depending on which light chain is increased. And if you divide the higher by the lower, you will, if you have this ratio of more than 100, you will have a higher risk of progression. And you can see here, I just go back to the other slide, this in brackets is the percentage of patients with smoldering myeloma, showing those parameters. Here in this case more than 60% plasma cells, here 17%, here 5% in those different groups. It was not mentioned here, but mentioned in this group of again about 15% of smoldering myeloma patients with this risk factor. And there's another factor that was incorporated into the new definition, saying that if you have more than one focal lesion, meaning a focal accumulation of plasma cells, of malignant plasma cells in the bone marrow detected by MRI, is also a prognostic factor, and this was shown by the Greek group and by our group. And again, you find it in about 15% of patients, and you can see here again those, it's just the opposite, but you can see here the steep increase in the patients with more than one focal lesion, and here the steep decrease again with the patients with more than one focal lesion in MRI. We, because this was our work, we looked into those patients in follow-up, and we found out that some of the patients, if they have more than one focal lesion, but if they stay the same, it's a low risk of progression. But if there is a progression of disease, I can see here, these are more than one focal lesion, goes up very steep. And if you look in those patients in follow-up, if you don't have to look into the details, but I can tell you that if the patients stay in the same stage, meaning that if there are several focal lesions but they stay the same, they don't grow, it's not a high risk of progression. But if they grow or if there are appearing new focal lesions, it is of very, very high prognostic significance for progression into symptomatic disease. The same was shown again by a Spanish group, showing that so-called evolving smoldering myeloma, meaning that the monoclonal protein measured in serum or urine is going up very steep. It again is a bad prognostic factor, meaning there is a high dynamic in this disease. So there is a kind of an algorithm how to go on with those new definitions. I said I will tell you about the CREB criteria, but I think I have to tell you now so you can really appreciate what they mean. C is a so-called is from calcium, like hypercalcemia, if you have a high calcium level in serum. R is for renal damage or renal impairment, meaning the kidney has decreased in function. A is for anemia, or the replacement of the physiological hematopoiesis in bone marrow, and B is for bone disease, meaning there are osteolysis in the bone. Those are the CREB criteria, and they define a symptomatic myeloma. And if you don't have CREB criteria, as I said, those patients were defined to now as asymptomatic or smoldering myeloma patients. And now if you have those patients, by definition, in smoldering myeloma, you look if they have the plasma cell percentage in bone marrow of 60% or more, and if this is the case, we call them active myeloma. If they have an increase in their serum free light chain ratio, as mentioned, of more than 100, it's or 100 and more, again you have active myeloma. And again you look into MRI, if you find more than one focal lesion, it's again active multiple myeloma. So those active myeloma patients, besides not having CREB criteria, should be treated and called multiple myeloma and not smoldering myeloma again. And here's a summary of this new definition of the symptomatic disease, and by that again a definition of the smoldering myeloma, because we have those high-risk smoldering myeloma patients now being called multiple myeloma, and we still have those other smoldering myeloma patients who are called still smoldering myeloma. So the definition now is more 10% or more plasma cells, monoclonal plasma cells in bone marrow is the definition of myeloma or smoldering myeloma, and they have to have so-called myeloma defining events, or MDEs. First of all, it's this so-called CREB criteria, as I mentioned: hypercalcemia, renal impairment, anemia, or bone lesions, and they don't have to appear all at once, but it's enough if you have one of those criteria, then it's a so-called symptomatic myeloma. But with the new definition, you also have an active myeloma and not smoldering myeloma anymore if you have those clonal bone marrow plasma cells of 60% or above, as mentioned, and if you have a serum free light chain ratio of 100% or 100 or above, and if you have more than one focal lesion in magnetic resonance imaging, again you have this so-called multiple myeloma, not symptomatic because those patients don't have pain or don't have symptoms of renal insufficiency, but they are called multiple myeloma by the new definition now because they have a very high risk of progression, as Dr. Mateos mentioned. So in American they like the acronyms and they don't call it CREB now, they call it SLIM CREB, and S is from 60%, L from light chains, and M from magnetic resonance imaging. So you have an easy to remember definition. So from this we get, and also this was a definition of symptomatic or of multiple myeloma, so we get a new definition of smoldering myeloma with a serum M protein of more than 30 grams per liter. This didn't change. Now we mentioned that if the urinary monoclonal protein is of 500 milligrams per day or more, it's also defined as smoldering myeloma, but in bone marrow the plasma cells will have to be by definition more than 10%, but below 60%, because if you have a plasma cell percentage of more than 60%, it's called multiple myeloma. There are no myeloma defining events or amyloidosis, but I think it's too much to talk about amyloidosis now, but this is the definition. And with this, I'm finished with my slides, and I hand over the microphone again to Dr. Mateos.
Okay, so
hello.
I'm changing. Yeah, we can hear you, Dr. Mateos. So I'm changing the screen. So, okay, now we can see your screen. Thank you.
Okay. Here, so we have reviewed the diagnosis of smoldering, how we evaluated the prognosis, so the risk of progression to symptomatic disease, and now let's move on to evaluate the treatment of smoldering myeloma, or probably better, the management of smoldering myeloma, because as Dr. Hillengaß previously said, the standard of care for the smoldering myeloma patient has been observation, so not treat anti-progression to symptomatic disease. The first exception to this standard management has been the definition of ultra-high-risk smoldering myeloma patients, that now they should be considered as myeloma and be treated immediately as symptomatic myeloma patients. But as I previously said in my previous presentation, low-risk smoldering myeloma should be probably followed as MGUS-like patients just once per year. Intermediate risk smoldering myeloma should be probably followed as true smoldering myeloma patients every 6 months. And the problem probably is for high-risk smoldering myeloma patients. So those patients in which we know that the risk of progression to systematic disease is approximately 50% within the first 2 years since the diagnosis. So do these patients can obtain a benefit from early treatment? Here in this slide you can see the prior studies, the first studies conducted in smoldering myeloma patients with conventional agents such as melphalan plus prednisone, thalidomide plus zoledronic acid, or even bisphosphonates. And if you look here, the benefit in terms of time to progression to symptomatic disease or overall survival is no benefit. So if we consider all these trials of course don't support the early treatment for smoldering myeloma patients. But the problem of these trials conducted many years ago is that in these trials, low smoldering myeloma patients, intermediate and high-risk smoldering myeloma patients were included. So probably some high-risk patients can obtain any significant benefit for this early treatment, but probably the low-risk subgroup of patients didn't obtain any significant benefit. And this was the reason why Spanish myeloma group decided to conduct this trial. You can see here in this slide in which we decided to plan an early treatment for smoldering myeloma patients, but at high risk of progression to symptomatic disease. And we focused on a series of 125 patients, and they were randomized to receive no treatment, the standard of care for this group of patients, versus lenalidomide plus low-dose dex. We selected lenalidomide plus low-dose dex as a treatment for these high-risk smoldering myeloma patients because it was a combination that it has been shown to be effective in symptomatic myeloma patients, and in addition because it was of oral administration and with an acceptable safety profile. You can imagine that the primary endpoint of our trial was to evaluate the time to progression to symptomatic disease. In other words, to show if the early treatment was able to delay the progression to active myeloma, but also we evaluated if lenalidomide plus low-dose dex was or not effective in high-risk smoldering myeloma patients in terms of response rate. And you can see as the answer is yes, and most of the patients, 80% of the patients responded to this combination, some of them achieving complete remission, so the best quality of the response we can achieve in the treatment of myeloma patients. But probably this is one of the main graphs coming from this trial, because here you can see as the early treatment with lenalidomide plus low-dose dex resulted into a significant benefit in terms of time to progression, median time to progression not reached, versus 21 months for patients who didn't receive any treatment. This median time to progression was concordant with the median time to progression I previously showed you for high-risk smoldering myeloma patients. In fact, now the median follow-up of this trial is more than 5 years, and you can see as most of the patients really progressed to symptomatic disease. This was important, the benefit in terms of time to progression, but also it was very relevant, the benefit in terms of overall survival, indicating that the early treatment with lenalidomide plus low-dose dex resulted also into a significant benefit in terms of overall survival. Even when we evaluated the overall survival from progression to active disease, this overall survival was also longer for patients who received early treatment with lenalidomide plus low-dose dexamethasone. Another important point to discuss was the toxicity profile, of course, because we know that we were dealing with patients in which the standard of care was not treatment, and here you can see as the toxicity profile was very acceptable, and in fact most of the adverse events were of grade 1 and grade 2, and also we collected the toxicity profile in the patients who didn't receive any treatment, and you can see as also some patients with a high-risk smoldering myeloma with no treatment, they had also asthenia, constipation, diarrhea, and 26% of them had infections of grade 1 or grade 2. So what is the future? The future is a significant number of clinical trials that you can see here in this slide, current studies that they are currently ongoing in smoldering myeloma patients, but at a high risk of progression to symptomatic disease. And this is important because we have to focus on this group of patients at a high risk of progression to symptomatic disease. Here you can see a trial that is currently ongoing in the US with lenalidomide alone versus observation, in which you can see as the phase 3 is currently ongoing. And I would like also to show you this phase 2 trial, very attractive for high-risk smoldering myeloma patients, conducted in the US, in which carfilzomib, a second-generation proteasome inhibitor, a new drug very effective in symptomatic myeloma patients, has been added to lenalidomide plus low-dose dex, and you can see here as all patients achieved complete remission. The number of patients included in this trial is very small, and of course we have to wait to know much more consolidated results, but this is my conclusion about the treatment or the early treatment for high-risk smoldering myeloma patients. In our trial, we showed that lenalidomide plus low-dose dex is effective as early treatment with a significant benefit in terms of time to progression and also in terms of overall survival. Numerous clinical trials with several drugs are currently ongoing in this group of patients, and I think that altogether these results support to change the current treatment paradigm for this patient population, and probably we can speak about early treatment in selected asymptomatic myeloma patients. What is our next step within the Spanish myeloma group? For Spanish patients, at least at the present time, we are going to start this attractive trial in 90 patients with high-risk smoldering myeloma, younger than 65 years, in which we are going to try to administer an aggressive option of therapy, including carfilzomib, lenalidomide plus low-dose dex, transplant, consolidation, and maintenance. We are going to evaluate the minimal residual disease after each step of the treatment, and the objective of this trial is to cure some patients with smoldering myeloma at high risk. In conclusion, and this is my last slide, first, it's very important to confirm and to do the correct diagnosis of smoldering myeloma. The next step is to stratify to the smoldering myeloma patients according to the risk of progression to symptomatic disease, low risk, intermediate risk follow-up every year or 2 times per year, high risk, if possible, close follow-up, if possible, candidates to clinical trials to better know the disease, and it would be very interesting that all physicians can refer high-risk smoldering myeloma patients to academic centers in which a clinical trial for this patient, for this group of patients, is currently ongoing. And as Dr. Hillengaß said during his presentation, ultra-high-risk smoldering myeloma patients should be called now multiple myeloma, and they should immediately start systemic therapy. And I finish here my presentation. And now I think that it's the turn again to Alfonso to answer to your different questions.
Okay, so thank you very much, Dr. Mateos and Dr. Hillengaß. Well, I hope I'm not going to be the one that answering the questions with you, but anyway. So, well, I think the presentation has been very, very clear. I really thank you both for such a clear explanation. We have already received some questions, most of them by writing, but I want to remind you that you can that you have 2 possibilities to make your questions. First of all, if you can press the raise hand button. There is a small icon on your screen. If you press it, I will see it, and I will unmute your microphone so you can do your questions live. And the other possibility, as some of you has already done, is to send the questions by writing. So I'm going to start asking you the questions. Both of you, Dr. Mateos and Dr. Hillengaß, you have your microphone open, so you can decide whether to answer one or the other. So the first question is, I was diagnosed with multiple myeloma 5 years ago, and I am very interested in the genetic origin of the disease. I have 2 sons of 29 and 32 years old, and I would like to know whether it could be good for them to go through some prior diagnosis tests to prevent myeloma in the future.
Should I answer?
Yes,
maybe I start and you can add maybe. This is a very good question, and it is asked to me by a lot of patients, because we talked about genetics, and you think maybe genetics could also affect, and I said in the presentation that we do a family history. So on the one hand, when we talk about genetics, like those deletions and translocations, it's not about the genetics of you or your children or your siblings, but it's on just the genetics of those plasma cells. We get those plasma cells out of the bone marrow, we do enrichment of those cells, and then we examine those cells, only those malignant cells, and look for the changes. So this is not something you can give on to your children, but there are data on large groups of people, mainly from Scandinavia, and there was found that some families have more myeloma or MGUS patients in their family, but this is extremely rare. And we do not recommend to look into those, to bring your children to the doctor, because the risk to have develop a myeloma as a child or a first degree relative of a myeloma patient, the risk is about 8 times the risk of the normal population, and the normal population has a risk of 4 to 5 per 100,000. So it's, let's say, 4 times 8 per 100,000. It's still very, 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 very low, and there's no reason, at least in my opinion and in our practice, we do not recommend to bring children and siblings to the doctor, because there is no really high risk for them to develop the same disease as you.
Okay, thank
you. I absolutely.
Yeah, sure.
I absolutely agree with the comment done by Dr. Hillengaß, and it's very important. Patients with myeloma can be calm, can be quiet, because the probability of their relatives have also a myeloma is very rare, and the best option is to do nothing.
Yes, definitely.
Okay, thank you both for this answer. So the next question comes from Maria, and is regarding the treatment of the smoldering myeloma. She asked, are new drugs such as carfilzomib or panobinostat or any other monoclonal antibody useful for the treatment of a smoldering myeloma in case lenalidomide-based regime fails? And she asks also if there are any available ongoing clinical trials using these drugs.
Yeah, there are many clinical trials currently ongoing in smoldering myeloma. I have put a small list, but I know that monoclonal antibodies are going to be evaluated in high-risk smoldering myeloma patients in the setting of clinical trials. And in fact, I know that in the US, a new trial combining alotuzumab, a monoclonal antibody, plus lenalidomide plus dexamethasone has just started some months ago. Other new monoclonal antibodies, such as anti-CD38 monoclonal antibodies, are going to be also evaluated in the setting of clinical trials in high-risk smoldering myeloma patients. I don't know about panobinostat, but my answer for Maria is that many clinical trials are going to be currently ongoing and are going to start in the near future for high-risk smoldering myeloma patients. She also was asking by carfilzomib, and I can say her that the new Spanish trial will incorporate carfilzomib as part of their treatment for high-risk smoldering myeloma.
Okay.
And also I would like to add just a comment, because this trial is going to start in Spain, probably this month in April or at the beginning of May. But after the trial is started, there is one possibility to expand the trial to other countries, such as Germany, Greece, Italy. So this trial probably it's going to be opened to other European countries.
Well, thank you for the answer for this remark, Dr. Mateos. I'm receiving many questions through chat. I ask you not to be shy. If you want to do it in my microphone, just tell me. So, next question comes from Charlie, and he says, "Hi, my name is Charlie, and I was diagnosed monoclonal gammopathy in June 2011. My doctor told me that we need to wait and look if it did progress to multiple myeloma or not. He told me not to worry because the possibilities that it might progress to a myeloma are low, but I'm 47 years old and it's something difficult to cope with. So do you think that I can take an advantage of treating this now instead of waiting for the myeloma to appear?"
So my opinion is this patient can be quiet, because the probability of progression to myeloma for a patient with a monoclonal gammopathy is really very low. And in fact, we don't know what is her monoclonal component, but in addition, the monoclonal component is very low, inferior to 1.5, so the probability of progression is very low. And I consider, and this is a personal opinion, that no clinical trials are going to be conducted in MGUS patients, because I think that it has not many sense to evaluate the probability of early treatment in a disease in which the risk of progression is really very low.
I absolutely agree, and I couldn't stress that more. It's really not a reason to have treatment, because you will just have side effects with no really reason to believe that you will have a benefit of an early treatment. I know that it's hard, and I have a lot of patients talking to me about this problem, knowing there could be a risk of developing a cancer. I know that this really has to be difficult, but please do not treat this actually I try to tell my patients that this is not really a disease. MGUS is just a lab finding. It's a finding that if you didn't have had the lab examination, you wouldn't even know, and it might not even if you are young, it might not even become relevant within your lifespan. But if it becomes, I think it's important to monitor it, as your doctor said, and you should go for the monitoring meetings with your doctor, but there is no reason to treat an MGUS in our opinion, because it will not really, there's no reason to believe that there will be a benefit of an early treatment of MGUS. And as Dr. Mateos really very nicely showed you, the treatment, the early treatment, is only for very high, ultra high risk smoldering myeloma, which is, let's say, 2 steps ahead of MGUS. So please do not treat MGUS. Live a healthy life, as it's recommended by every doctor. Do sports, drink a lot of water, eat, as we say, Mediterranean food. I don't know really what it is exactly, but I think it's good, because all the Spanish and Italian people I know look good.
Italian pizza.
Yeah, maybe that. Yeah. Now, really, try to have a healthy lifestyle, and then it's the best you can do for yourself.
Yeah, by sure.
Okay, I never thought like pizza in a treatment for myeloma. So
we should conduct a trial. I will participate, even if not having MGUS.
Okay, so next question comes from Dana. She has sent us many questions. I will split them in the during this part of the webinar. So the first question is contrast required for a spinal MRI, for magnetic resonance imaging? And she says, in case it is needed, why is it required? Well, she said that she would like to fully understand, as she has had MRIs of her full spine without gadolinium to date, and she, of course, is a smoldering multiple myeloma patient.
Mm-hmm. Maybe I can answer this because
yes, of course.
Because it's the main topic.
He's an expert in imaging assessment.
Thank you very much. Yeah, actually, I really like to think about this, and we talked about this a lot. And some doctors say they need contrast. If you have a radiologist who has at least seen several multiple myeloma patients, he will be absolutely able to see myeloma infiltration without any contrast. You really do not need contrast. There are very, very few indications in myeloma when you really need contrast. If there's a change, you can really not differentiate. But if it's if it's a negative MRI without contrast, you don't need contrast at all. And we compared that there's really not a big benefit of contrast. There was data or an observation that contrast gadolinium might be bad for myeloma cells, meaning that myeloma cells can grow more if there is gadolinium within the system. But we have looked into that, and we looked into more than 300 patients, and we found out that there is no bad or no high risk by using gadolinium, but you really do not need it. So you don't need gadolinium contrast agent for these examinations for multiple myeloma, not even for smoldering myeloma, not for MGUS. So your doctor did everything right. You don't need, it's a spinal MRI is very good to have, but you don't need contrast agent.
So that was a very clear answer. We have another question from France, and he says, are the diagnosis tests available at the vast majority of hospitals, or would you recommend to go to a specialized myeloma center? He says that he lives in the Netherlands, but he's interested in the global availability of these tests in terms of access.
I think it's difficult to know if which clinics have those tests available. I think in Europe most of the countries and most of the clinics in those countries have those tests available because they are not too difficult. Maybe the free light chains are not established in every clinic, maybe not MRI and PET-CT, but most of those tests, at least the blood counts, the lab results of biochemistry, the bone marrow examination should be really available in every country, in every clinic. And if it's not, maybe you should just ask your doctor, and if it's difficult for him to provide those tests, you should go to an academic center, as Dr. Mateos already mentioned. And in Germany it's like this, most patients go to their private practice doctor, and if this doctor is not sure what to do, he sends his patients to the centers. And especially if you're looking for clinical trials, I think it could be a very good idea to go to centers, because in Germany we are the biggest center and we have more trials because we are focusing on multiple myeloma, and this could be beneficial, but I think the tests should be available in most clinics.
Yeah, I absolutely agree with Jens' opinion. I think that the diagnosis of smoldering can be done in all centers because it's very easy, only considering the M component and the plasma cell bone marrow infiltration. What your physicians have to do is to stratify according to the risk of progression to symptomatic disease, and in most centers, setting free light chain, even MRI, bone marrow is available to well stratify the risk of progression. And as I previously said, what your doctor has to do is, if you have a high-risk smoldering myeloma patient and there is an academic center close to your center in which a clinical trial is open, please refer the patients to these academic centers.
Okay, thank you very much for your answer. The next question is for Dr. Mateos from Nana, and she's asking if HR smoldering myeloma patient did not progress with the smoldering myeloma patient did not progress within the first 2 years, does the 50% risk progression decline? And she mentioned that this is the group that you reference that has a 50% risk to progress within the first 2 years.
Yeah, this is a very good question, because if you remember the curve I presented of our trial, in which I showed the risk of progression to symptomatic disease for patients at a high risk, after the first 2 years the risk is not declining, because in fact in our trial we have a series of 60 patients at a high risk of progression to symptomatic disease, and after a median follow-up of approximately 5 years, almost all patients, 90% of the patients, have already progressed. The exception have been 5 patients who they have not progressed yet to symptomatic disease, and this very small group of patients were really at high risk of progression to symptomatic disease. Why didn't they progress still at the present time? We don't know. We have done a new bone marrow to this small fraction of patients to know something else about the biology of the disease. But if we look at our curve representing the follow-up of 60 high-risk smoldering myeloma patients, I think that the risk did not decline, because at the end of the day most patients finally progressed.
Good. Thank you very much, Dr. Mateos. So next question is from a patient, and she's asking us, you have mentioned the free light chain serum diagnosis, And she said, could you explain a little more how this test is performed? Is it painful? I have to do it, but I was nervous at the doctor's practice, so I didn't ask her about it.
Because I mentioned it first, maybe I can answer. It's not painful, it's just a blood draw out of the vein, and then it's just a lab examination. So you don't have to be anxious about that. Just blood, and this will be sent into the lab, and then the doctor will have the free light chain test. So I'm sorry that I haven't mentioned that earlier. Most of those tests are just blood drawn out of the vein.
Okay, so thank you very much.
Yeah, and in fact, I just only to add that serum free light chain is available in most centers now in all European countries.
Good. Thank you very much, both. So the next question is related with what were you talking about, what to eat or good healthy habits for the monoclonal gammopathy patients. So it's a question from Martin, and he's asking, is there any treatment like curcumin or any special diet for Angus patients?
Yeah, curcumin or green tea or a diet risking fat grass acids have been evaluated in smoldering myeloma patients. And in fact, there are trials published about this type of agents. But unfortunately, I think that there is not any significant benefit. So I think that a healthy life is always good for all patients, and of course also for smoldering myeloma patients. But honestly, I don't consider that people who drink many green tea or curcumin are going to have any significant benefit.
I absolutely agree. Besides, the former head of our department published something about green tea, and he drank it by himself, but it was not really a clinical trial. So if you like green tea, drink green tea, but if you don't like it, you don't need to drink it. So yeah, just live as mentioned several times now. Live a healthy lifestyle as it's recommended for everyone, and you will do the best for yourself.
Thank you for that answer. So the next question comes from Dana, and she's asking us, will all smoldering multiple myeloma patients eventually progress given enough time, or is there a group who may never progress even after 20 years or more?
Yeah, of course, if you remember the curve, there will be a subgroup of patients in which the risk of progression is similar to MGUS-like patients, and there will be, by sure, patients with smoldering myeloma patients who never will progress to symptomatic disease.
Yeah,
There's
nothing to add to that, because it depends. It's just a statistical evaluation, and every patient is different, and if you are living long enough, it might be statistically possible that you develop myeloma, but it could also be that in high age you die of something else. It's very difficult to say, but there are those risk stratifications to say, okay, you have a high risk to develop myeloma early, or you have a low risk to develop myeloma early. And if you, yeah, it depends also when you start to measure. If you are very young and measure, as the other patient mentioned, he's very young and he wants to know how to proceed. But yeah, it's just statistics. You are the patient, and the doctor will look at you as individual.
Okay, thank you. We still have a few more questions, but I remind you that you can still send. I think we still have like 10 minutes, so there's still time for questions. So remember, you can write it down or press the raise hand button to use your microphone. So next question is, could allogenic stem cell transplant be a therapeutic option for smoldering myeloma patients?
Stem cell transplantation?
Allogenic.
Allogenic stem cell transplantation. Oh, I think that at the present time is too early to consider allogenic stem cell transplant for smoldering myeloma, because you have to know that allogenic stem cell transplant is not a standard treatment for symptomatic myeloma patients, and there is not a good consensus when to do allogenic stem cell transplant in symptomatic myeloma patients, and in which moment and which patients are going really to obtain a significant benefit from allogenic stem cell transplant. So my opinion is there is not any role for allogenic stem cell transplant in smoldering myeloma patients, even in high-risk smoldering myeloma patients, because you have always to put into a balance the benefit and the risk of the procedure you are going to receive or we are going to plan to a patient. And at the present time, the transplant-related mortality with allogenic stem cell procedure is very high to offer it to a patient with a smoldering myeloma.
I totally agree, and I think the harm you do a patient, you could do a patient, it's not always, but you could do a patient with those side effects of allogenic transplantation the risk is very, very high compared to not having symptoms by the smoldering myeloma. And as Dr. Mateos mentioned several times, there are so many very interesting and very helpful and not too aggressive studies going on for smoldering myeloma, and they are very much more recommendable for smoldering patients, because as Dr. Mateos said, if you have this high risk of side effects with a not really sure benefit for the patient, I also absolutely would not recommend to perform an allogenic transplant. The idea behind that is quite good, because there should be a help of the immune system, of the new immune system you transplant to the patient. There should be a help against the cancer, but the problem is it does not really work very well in myeloma patients, and we don't know yet which patients, even the symptomatic patients, which patients really benefit, and we need a lot more scientific research to really differentiate which patient could have a benefit from allogenic, and I would not recommend, again, to do it in smoldering myeloma.
And this is all, as we are going to record, as we are recording this webinar, just to keep the record. What's your opinion on autologous, the role of autologous stem cell transplant, or even some small range of patients are taking sometimes a benefit for having like 2 autologous transplants in a 6 to 12 months period, like a tandem transplantation? Do you think there is a role for this kind of transplants in smoldering myeloma patients?
I think Dr. Mateos will conduct a study for that.
Yeah, okay. In fact, this is an experimental approach, because you have to imagine that 5 or 10 years ago, smoldering myeloma, the standard of care was not treatment, without any doubt. So everybody, when a physician did the diagnosis of smoldering myeloma, the standard of care was watch and wait. So I will follow every 3 months, every 6 months, but you are not going to receive any treatment. And this was the standard of care. When Spanish Myeloma Group conducted the first trial with lenalidomide plus low-dose dex, we really obtained a significant benefit in terms of time to progression to active disease, also in terms of overall survival for high-risk smoldering myeloma patients. But this trial was published in 2013, so a couple of years ago, in fact 1.5 years ago, and this has been really the first trial showing a significant benefit for high-risk smoldering myeloma patients. So this is the reason why scientific community in myeloma remains even today very conservative with the early treatment of smoldering myeloma patients, even with high-risk smoldering myeloma patients. So Spanish Myeloma Group is probably aggressive, and it's probably, I repeat, aggressive with high-risk smoldering myeloma patients, and we planned autologous stem cell transplantation for high risk, and our feeling and our rationale was if we consider that high-risk smoldering myeloma patients are very similar to symptomatic multiple myeloma patients, why not to offer the same option of therapy for high-risk smoldering myeloma patients? And this is the reason why we decided to conduct this trial offering autologous stem cell transplant for high risk. But we don't know the results yet, and of course we have to wait to obtain the results. Why transplant, autologous stem cell transplant for high-risk smoldering myeloma patients? Because you have to know that allogenic stem cell transplant has a very high transplant-related mortality. Autologous stem cell transplant is associated with a very low transplant-related mortality, and is a simple and safe procedure to be offered to asymptomatic myeloma patients.
Yeah, absolutely agree, and I'm very much looking forward to seeing the data of the trial of Dr. Mateos.
Thank you very much for giving us this last update on this topic. So we have 3 more questions. The next one comes from Erica, and she's asking, how do you measure the risk-benefit of treating a patient in a very early stage of the disease instead of doing an active surveillance?
No, we don't have, and so it would be of great value to incorporate quality of life questionnaires in our trial, but we didn't do so, we can't evaluate. We don't have any objective measurement for the benefit of the early treatment, but what we think is that we are doing an approach similar to oncologists are doing with solid tumors. And I usually say to my students, imagine that you have a small node in your breast, so a PAF, a punction is done, and the diagnosis is adenocarcinoma, breast adenocarcinoma, and the oncologist said, okay, don't worry, when you have a liver metastasis, I will treat you. Now watch and wait. And this is what we were doing with smoldering myeloma patients. And we consider that high-risk smoldering myeloma patients obtain a significant benefit from early treatment, because what we are preventing is CRAB symptomatology described by Dr. Hillengaß, consisting on lytic lesions. And lytic lesions means bone fracture or renal impairment, and some patients, when they develop a renal impairment, they finally become dialysis dependent, or with anemia or hypercalcemia. So this CRAB symptomatology affecting to the quality of life of the patient is what we are trying to prevent with this early treatment, but of course in selected high-risk smoldering myeloma patients.
Thank you, Dr. Mateos. We're going with the last 2 questions. And this question is for you, Dr. Mateos. It's regarding the CESAR trial. And it comes from Nana, and she says, in CESAR trial, will those with high-risk cytogenetics as well as standard-risk cytogenetics be participants?
Yes, of course, but the criteria that we have decided to choose for the definition of high risk are those patients who have more than 3 grams of monoclonal component plus more than 10% of plasma cell bone marrow infiltration, or for those patients who didn't meet both criteria. We are going to evaluate the plasma cell within the bone marrow, and when most of the plasma cells are malignant plasma cells plus immunoparesis, so the uninvolved immunoglobulins are decreased, these patients are also considered as high risk, and they can be included in the trial. If a patient has a smoldering myeloma and the high risk is only defined by the presence of cytogenetic abnormalities, we are not going to include smoldering myeloma patients just with cytogenetic of high risk. So, in summary, we are going to consider the Mayo risk model and the Spanish risk model for the definition of high risk. I don't know if I have correctly answered the question.
I think so. I will with Dana to to reply, but I think so. Well, so I proceed with the last question to both of you, and it comes from Alina, and she asks, you have mentioned the new definition of multiple myeloma. With this new research and new findings, do you think we are in the way to find a cure? And she's also mentioning, this is a devastating disease and I really appreciate the work you do for the wellness of patients.
Yeah, thank you very much. And I think the reason, as we said, the reason why we want to treat it, and as Dr. Mateos just said, the reason why we want to treat earlier is that we are really aiming to cure some myeloma patients. And I absolutely agree with Dr. Mateos concerning the fact that if we wait until there is kind of a metastatic disease with bone destruction, whatever, if we have the chance to treat earlier, it should be. But we also have to be very careful not to treat too early, because nearly every treatment also has side effects, and we don't want to harm any patients without any necessity. So I think we are on a way to a cure. Maybe we are not there yet, but there's a lot of research on this topic. We are looking into so-called minimal residual disease, looking if we can define a real cure if we don't find any plasma cells anymore. And I think we are on a way. Maybe we are not there yet, but we are really working very, very hard. A lot of researchers worldwide are working very hard to find a cure for this disease, and we are really, I think we really want to come there, because this is the goal we are going for, and I think a lot of really smart people are working on this, and it's really an honor and a pleasure to work with those people. And I think especially Dr. Mateos is a pioneer in this field to treat early and maybe to find a cure for that.
Yeah, I absolutely agree. And probably everybody has seen sometimes a graph representing the natural history of the disease. And we know that when a patient is diagnosed of symptomatic multiple myeloma, the greatest benefit is going to be obtained from the first line of therapy. But the natural history of the disease are courses of remission and relapses until the disease becomes refractory. So what we are going to try to do is to early treat before the symptomatic disease occurred, and I consider that it is the only way to try to plan a cure for this group of patients.
Great, thank you very much. There is one last question from Dana. Well, she said that that your explanation was very clear regarding the CESAR trial, and she also asked if the CESAR criteria, if it is based upon either the Mayo or the PETEMA risk models.
Both. One, a Mayo or PETEMA, both criteria. But it is not necessary to meet both Mayo and PETEMA. Patients can meet Mayo clinical risk or PETEMA risk.
Great. Well, so thank you very much both. It seems that we have run out of time, so before we end with this webinar, I would really like to thank you both, Dr. Mateos and Dr. Hillengaß, on behalf of Myeloma Patients Europe for sharing with us your valuable time. I think it's been a very fruitful evening, knowing more about this particular case or stage of multiple myeloma, and I really hope that we're on the road to find a cure for this disease in the near future. I would like also to say thanks to all of you who joined us during this evening, and just remember that the webinar recording will be soon uploaded on the Myeloma Patients Europe website. So without any further ado, I encourage you to stay connected with us and to follow our upcoming activities in our website and in our social channels like Facebook and Twitter. And we also strongly recommend you to check our member section so you can contact your local myeloma organization just in case you haven't done it yet. So we're looking forward to see you soon in our next webinar. And once again, thank you very much for trusting Myeloma Patients Europe, and I wish you all a very good evening. Goodbye, and thank you once again, Dr. Mateos and Dr. Hillengaß.
Oh, thank you to you for the organization, and thanks for all patients and their relatives that they have been attending the meeting, and of course myself and also I think Dr. Hillengaß are available to answer all questions you have even out of the session.
Yeah, thank you very much for the great organization, and it was a pleasure and an honor to be part of it.
Thank you very much. Have a good evening and take care.
Okay, bye.
Goodbye.